Good day everyone, I am Maria Jamie Teres Ibo and I'm going to discuss emergency obstetric and newborn care. In the Philippines, there are about 3 million women getting pregnant every year. The National Demographic Health Survey 2003 or NDHS revealed that about 44% of women are pregnant with their children or first children at ages 20 to 24 years. And 61% at ages 15 to 19 years. Because pregnancy is a physiologic process, the health sector aims to make pregnancy for the woman and gestation for the fetus as safe and as medically uneventful as far as possible. In 2003, the mean number of children born to a Filipino woman upon reaching the age of 40 to 49 years is 4.3 with an average total fertility rate of 3.5 children per woman. The high fertility rate coincides with the low contraceptive prevalence rate at 47.3% among all Filipino women at reproductive age 15 to 49 years old and 70.6% among married women. The age group 35 to 39 years has the highest percentage of using contraceptive, while 15 to 19 years old have the lowest percentage using any contraceptive method. The situation leads to more pregnancies and deliveries among Filipino women. At greater risk are women getting pregnant below 18 years old and those who are more than 35 years old. Chronic illnesses such as iron deficiency anemia, tuberculosis, hypertension, cardiovascular disorder, diabetes in pregnancies are at risk that would harm the mother and the unborn. The Philippine Health Statistics 2000 or PHS revealed that 25% of all maternal deaths are due to hypertension, 20.3% to postpartum hemorrhage, and 9% are due to pregnancy with abortive outcomes. The underlying cause of maternal deaths are delays in taking critical actions, delay in seeking care, delay in making referral, and delay in providing appropriate medical management. Other factors that contribute to maternal deaths include closely spaced births, frequent pregnancies, poor detection and management of high-risk pregnancies, poor access to health facilities brought about by geographic distance and cost of transportation, as well as health care and health staff who lack competencies in handling obstetrical emergencies. EMOC or Emergency Obstetric and Newborn Care is defined as a set of living-saving interventions that treat the major obstetric and newborn causes of morbidity and mortality. To assess the level of care, these functions are classified as Basic Emergency Obstetric and Newborn Care or BEmONC and Comprehensive Emergency Obstetric and Newborn Care or CEmONC. So, first is BEmONC. Basic Emergency Obstetric and Newborn Care is a strategy in coordination with DOH. It entails the establishment for facilities that provide emergency obstetric care for every 125 population. These are the services that every woman has to receive before and after pregnancy and or delivery of a baby. First is antenatal registration. Next is tetanus toxoid immunization. Then micronutrient supplementation. Then treatment of disease and other conditions. Clean and safe delivery. Support to breastfeeding. And family planning counseling. First is antenatal registration. pregnancy poses a risk to the life of every woman. Pregnant woman may suffer complication and die. Every woman has to visit the nearest health facility for antenatal registration and to avail prenatal care services. This is the only way to guide her in pregnancy care to make her prepare for childbirth. The standard prenatal visit that a woman has to receive during pregnancy are as follows. In first visit of prenatal visit should be as early in pregnancy as possible before 4 months or during first trimester. The second visit should be during the second trimester. The third visit is during the third trimester. After 8 months of pregnancy till delivery, the prenatal visit should be every 2 weeks. Next is tetanus toxoid immunization. Neonatal tetanus is one of the public health concerns that we need to address among newborns to protect them from deadly diseases. Tetanus toxoid immunization is important for pregnant women and childbearing age women. Both mother and child are protected against tetanus and neonatal tetanus. A series of 2-dose tetanus toxoid vaccination must be received by woman 1 month before delivery to protect baby from neonatal tetanus, and the 3 booster dose shots to complete 5 doses following the recommended schedule provide full protection for mother and child. The mother then is called as fully immunized mother or FIM. Next is micronutrient supplementation. It is vital for pregnant women. These are necessary to prevent anemia, vitamin A deficiency, and other nutritional disorder. So here are samples. Vitamin A, 10,000 IU. It is twice a week starting on the 4th of pregnancy. And remarks, do not give vitamin A supplementation before 4th month of pregnancy. It might cause congenital problems in the body. And iron, 60 mg over 400 mg tablet daily. Treatment of disease and other conditions. These are other conditions that might occur among pregnant women. These conditions may endanger her health and complications could occur. First, follow first aid treatment. So here are the sample conditions or diseases and what you need to do and do not give. First is difficulty of breathing or obstruction of airway. What to do is clear airway, place in her best position, refer woman to hospital with emergency obstetric care capabilities. Next is unconscious. Keep on her back, arms at the side, and tilt head backward unless trauma is suspected. Then lift chin to open airway. Then clear secretion from throat. Give IVF to prevent or correct shock. Then monitor blood pressure. Use and shortness of breath every 15 minutes. Then monitor fluid given if difficulty of breathing and puffiness develops to stop infusion. What do not give? First is do not give oral rehydration solution to a woman who is unconscious or has convulsion. And do not give IVF if you are not trained to do so. Next is postpartum bleeding. First, massage uterus and expel clots. If bleeding persists, first place cup palm on uterine fundus and feel for state of contraction. Then massage fundus in circular motion. Apply by manual uterine compression if ergometrine treatment done and postpartum bleeding still persists. Last is give ergometrine 0.2 mg IM and another dose of after 15 minutes. Do not give ergometrine if woman has preeclampsia or hypertension. Next is clean and safe delivery. The presence of a skilled birth attendants will ensure hygiene during labor and delivery. It may also provide safe and non-traumatic care, recognize complications, and also manage refer to the woman to a higher level of care when necessary. The necessary steps to follow during labor, childbirth, and immediate postpartum include the following. First is do a quick check upon admission for emergency signs. Is she unconscious or in convulsion? Vaginal bleeding, severe abdominal pain, looks very ill, severe headache and visual disturbance, severe breathing difficulty, fever, and severe vomiting. Next is make the woman comfortable. Establish rapport with client by greeting and interviewing to make her comfortable. Number 3, assess the woman in labor. Assessing the client is a reference guide for a health worker to determine its status during labor stage. This can be done by talking or taking the history of the following: last menstruation period or LMP, number of pregnancy, start of labor pains, age and height, danger sign of pregnancy. Taking the history through interview will help determine the client's condition during delivery of a baby. Number 4, determine the stage of labor. Labor can be determined when woman's response to contraction is observed pushing down and vulva is bulging, with leaking amniotic fluid and vaginal bleeding. A vaginal examination can be performed to determine the degree of contraction. Number 5 is decide if the woman can safely deliver. By assessing the condition of the client and not finding any indication that could harm the delivery of a baby, a trained health worker can decide a safe delivery for a woman or for a mother. Number 6, give support care throughout labor. There are many things that woman needs to do during labor. This will help deliver clean and safe and free from fatigue. These are encouraged to take bath and at the onset of labor, encouraged to drink. But not to eat, as this may interfere surgery in case needed. Encourage empty bladder and bowel to facilitate delivery of the baby. Remind to empty bladder every 2 hours. Encourage to do breathing technique to help energy in pushing baby out the vagina. Panting can be done by breathing with open mouth with 2 short breaths, followed by long breath. This prevents pushing at the end of the first stage. 7. Monitor and manage labor. There are different stages of labor to watch out any dangerous signs. 8 is monitor closely within 1 hour after delivery and give supportive care. 9 is continue care after 1 hour postpartum. Watch closely for at least 2 minutes. Watch at least 2 hours. Educate and counsel on FP and provide FP method if available and decision was made by a woman. Inform and teach counsel the woman on important MCH message. Birth registration, importance of BF, newborn screening for babies delivered in RHU at home within 48 hours up to 2 weeks after birth. Schedule to return consultation for postpartum visit. The recommended postpartum visit is the first week postpartum, preferably 3 to 5 days after delivery. The second visit should be 6 weeks postpartum. Support to breastfeeding. Most mothers do not know the importance of breastfeeding. A support care group like nurses have a critical role to motivate them to practice breastfeeding. Then, family planning counseling. Proper counseling of couples on the importance of FP or family planning will help them inform on the right choice of family planning methods. Proper spacing of birth and addressing the right number of children. Birth spacing of 3 to 5 years interval will help completely recover of the health of a mother from previous pregnancy and childbirth. The risk of complication increase after the second birth. So, next is CEmOC or Comprehensive Emergency Obstetric and Newborn Care. In an area at least 5,000 population and typically delivered includes all the function above or the BEmOC plus the capabilities of performing cesarean sections, safe blood transfusion, and provision of care to sick and low birth weight newborns including resuscitation. So, these are the difference between BEmOC and CEmOC. CEmOC should have the basic function of BEmOC while having these three. So, for any question, just PM me, and thank you for listening.